Hi, everyone. Welcome to our webinar on Help Alabama Families Impacted by Diabetes Expand CGM Access. I think we're going to wait a few more minutes until we have sort of max capacity of participants, but we will be jumping on shortly. We'll just give it one more minute and then we'll start. Looks like our participants have stabilized. So welcome again. Thank you so much for joining the Help Alabama Families Impacted by Diabetes Expand CGM Access webinar hosted by Families USA. Before we get started, I want to say that I'm keeping you and your families in my thoughts as Hurricane Helene makes landfall. I hope that you're all staying safe. If at any point you need to leave the webinar, we completely understand. We will send around a recording after the webinar is complete. And that being said, we're very excited that you've chosen to spend an hour of your time with us today and make space for a conversation about policy change that's much needed. Our speakers will discuss the burden of diabetes in Alabama, the role that CGMs can play in fighting the epidemic, and the state of play for CGM coverage. We'll also be joined by a licensed and certified professional midwife who will tell us more about her experience with diabetes, and we'll close out the webinar with further ways to stay engaged and connected to this effort. We can change the slide, please. So my name is Mackenzie Marshall. I'm a manager of government relations at Families USA, and I'll be the moderator for today's call. If you're not familiar with us, Families USA is the leading national voice for healthcare consumers, and we're dedicated to the achievement of high quality, affordable healthcare and informed health for all. Before we begin, if you experience any technical issues, and we can change the slide. If you experience any technical issues during this call, please feel free to add a message in the chat box to my colleague, Meg Rossiter. We'll have a Q&A session at the end of this call, so we ask that at any point, if you have any questions about any of the material that's covered, please feel free to add those questions into the chat box or into the Q&A function just throughout the speaking portion of the webinar. Let's quickly run through the agenda. We began with our welcome and introductions. We're about to transition into an overview of the current problem. So you'll start by hearing from me more about what CGMs are. Then I'll turn it over to Nancy Meganson, who is a licensed certified professional midwife and the legislative chair of the Alabama Midwives Alliance, about her personal experience with diabetes and pregnancy. Then we will move to Dr. Lamisha Chambers. She's a PhD MSW, who's the program director for Live Health Smart Alabama, UAB. She'll be sharing more about the importance of chronic disease education, access to critical healthcare tools and services from healthcare workers and providers. And then we will have our final speaker, Greg Howe. He's a senior fellow at the Center for Healthcare Strategies, who will be joining us to talk about expanding access to CGMs in Alabama and providing more information about the state of play in other neighboring states. We'll end with some time for you all to ask questions. And I'll introduce my coworker, Tasha Doxson, who is the Deputy Senior Director of Strategic Partnerships at Families USA, who's going to talk to us about future ways to engage with this effort. If you go to the next slide, you'll see all of our wonderful speakers. And then if we go to the following slide, I'll give a bit of an introduction about CGMs. So let's get into it. As many of you may know, diabetes impacts nearly 700,000 adults in Alabama and is increasingly impacting children across the state. Concerningly, type 2 diabetes diagnosis rates among children in Alabama are nearly doubled between 2017 and 2021, with a disproportionate increase among children covered by Medicaid. Unfortunately, people covered by Alabama Medicaid face challenges accessing an impactful tool for diabetes management, continuous glucose monitors, also known as CGMs. CGMs are temporary wearable medical devices that attach to the body and hold a sensor into your skin. This sensor is able to measure and report real-time glucose or sugar levels to your phone or another device. Through the use of CGMs, patients with diabetes can check glucose levels in real time, record patterns in glucose spikes and drops to share with their doctor, and even be alerted when the glucose levels become alarmingly high or low. After 7 to 14 days, patients replace the CGM sensor and continue monitoring their glucose levels. Blood sugar monitoring is the primary tool individuals with diabetes have to ensure glucose levels are in the target range. For people, including pregnant women and children with diabetes, glucose and sugar levels are some of the most important health information for diabetes management. By automatically and continuously collecting and reporting these glucose levels, CGMs reduce the burden on patients while keeping them and their medical provider informed. Research shows that CGMs are effective in reducing negative health outcomes, such as hypoglycemic events, and support general blood sugar management. In fact, real-time levels have been shown to reduce emergency room visits and hospitalizations by as much as 70%. Given that a large percentage of the $5.4 billion Alabama spends on diabetes related costs annually occur due to the high cost of addressing serious complications associated with diabetes. So just to repeat that, since I think I stumbled through it, that's 70% is a significant portion of the $5.4 billion Alabama spends annually addressing the high costs of serious complications associated with diabetes. CGMs have the potential to improve diabetes and disease management and subsequently reduce costs. They're a critical tool to help empower and inform individuals with diabetes, and we must make them more accessible and affordable. We need to expand Medicaid coverage of CGMs, including for pregnant women with gestational diabetes. I'm now going to turn it over to Nancy, who will tell us more about her personal experience as someone who's had gestational diabetes and as her experience being a midwife serving individuals in Alabama. So with that, I'll turn it over to you, Nancy.
There it goes. Hi, thanks for my invitation today. I'm glad to be here. I am a certified professional midwife, an Alabama licensed midwife, and a registered nurse residing in Tuscaloosa, Alabama. My role as an Alabama practitioner in midwifery is the provision of care during the antepartum, intrapartum, and postpartum periods. I provide this care option to West Alabama and maternal health desert families. As an RN, I previously have 5 years experience in a labor and delivery as a labor and delivery and well baby nurse. Any diabetes in pregnancy poses serious risk to the mother and the newborn. Most will discuss possible size increase of the infant at birth, possible shoulder dystocia, both leading to increased postpartum hemorrhage, cesarean rates, both emergent and planned. Birth injuries to the mother and the newborn. The other main risk I personally find we discuss less is the newborn risk for both breathing problems and hypoglycemia. This not only disrupts breastfeeding rates, but results in many NICU admissions, most of which I just mentioned above could have been avoided with better glucose management during the pregnancy. And even in every intervention I mentioned increases cost. The cost of the CGM is drastically less than a C-section or a NICU admission, and much higher value to improving Alabama maternal and newborn outcomes. In practice, I find most families want to be involved with their pregnancy and related conditions, especially when they know the why and have access to assessment and interventions that can easily be added to their lives. For me personally, I have 4 children, and the last pregnancy, who is 3 months old now, I was confirmed non-diabetic in the first trimester, and then later on with the gestational diabetes testing, I came back to have it. This was initially traumatizing for me as I hadn't had it before, but I knew this was not going to need to be monitored. I was going to need to check my blood sugars, and I began that journey of diet and exercise modification. I found the glucometer easy to use, but painful, cumbersome to remember, and occasionally I didn't even have it on me. I would miss glucose checks, not to mention feeling judged to have to pull it out around friends and family, like something I'd specifically done or not done to cause this to happen in this pregnancy. This judgment feeling that I was placing on myself also meant I might delay or skip a reading, something I'd seen in patients and did not understand. Didn't they know how important this was for them and their baby? Well, I knew, and I too was still falling less than perfect on my checks. Plus, I was having elevated fasting numbers, and that was drastically confusing. We didn't know if it was even higher readings at 1 or 5 a.m. or what was going on. I was concerned for my and my baby's health, the risk this posed, and possible need for medication. So, my licensed midwife and I talked. We decided to consult with a certified nurse midwife. She agreed that CGM is excellent insight for all diabetes and would be beneficial to my needs. We would also reevaluate in 2 weeks to see if I needed to add medication. While I still needed this prescription to attain the monitor, the CGM was not covered by insurance. I researched Amazon, CVS, everywhere to see what brand and coupons were available because I needed this. Ultimately, our existing Sam's Plus membership was the best option, and I could get a month supply at $80. But this was a blessing. This is not the case for most people. Most CGMs are going to cost $400+ a month when not covered by insurance. And even at the $80 range, this is not possible for the Medicaid covered community that are low income pregnancies. I used the CGM for the last 2 months of my pregnancy and into my postpartum. It was easy to apply every 2 weeks with minimal to no discomfort. It was in my upper arm location. And so I had the option to choose to cover it and be discreet and keep my healthcare private should I choose to. And that was important to me. The CGM drastically improved my real time correlation to glucose. I could correlate it with my intake, my activity, the feelings that I were having, sweats that were occurring that I had attributed to pregnancy. They now had a direct correlation. My postprandial numbers had not been terribly elevated, only a few times a week, but now they were all in range. And my fasting numbers went from 50% in range to 93% in range. CGM also gives you a GMI. It's kind of like your hemoglobin A1C that reports 90-day assessment. You can get it to report a 2 week or longer assessment. I was now tracking numbers in the non-diabetic range. Medication would not only not be needed for me, but my baby and I were finally back on a path of health and safety. I believe that it is due to the CGM that my baby was born safely, vaginally, the same size as his siblings, no injuries to either of us, and without hypoglycemia or breathing problems. He was perfect because my condition was managed timely and appropriately during the pregnancy with monitoring and interventions that normal life could commit to. I recommend without any reservation that CGM should be covered through Medicaid for those with type 1, type 2, and gestational diabetes. Thank you.
Perfect. Thank you so much, Nancy. That was really powerful. It's great to hear that you were able to access a CGM. It's a shame that many folks are not able to do so, and we want to make sure that we change that. Everyone who's going through a pregnancy should have access, as should individuals who are just living with diabetes day in and day out. So with that, Dr. Chambers, I'm going to turn it over to you to tell us a little bit more about diabetes, chronic disease management, and sort of the importance of healthcare tools like a CGM in improving overall health.
Perfect. Thank you, Mackenzie. So, as noted, my name is Dr. Lamisha Chambers, and I serve as the operations director for an initiative here in Alabama known as Live Health Smart Alabama. It was the inaugural Grand Challenge winner of a call to action that was put out by UAB's president back in 2019. So I joined the initial initiative roughly 3.5 years ago, and our focus is to reduce the overall incidence of chronic disease throughout the state of Alabama. So with many of us being from the state of Alabama, you know that we hover around the bottom half of all health rankings, from things as severe as cardiovascular disease to something as simple as access to fresh and nutritious food options. And so what Live Health Smart Alabama is attempting to do is to provide the education necessary for communities to understand the importance of prevention and wellness, good nutrition, and physical activity. Here in Alabama, most of us may be aware, some of you may not be, but about nearly 15% of all adults here in Alabama have a diabetes diagnosis. That's a little bit alarming, right? So roughly 30,000 people a year are being diagnosed as a newly diabetic individual. And medically, when you think about the cost that this is having, not only on the health system, but also on employers, we're reaching in a quick manner roughly $9,100 per person affected by a chronic disease. So essentially it's saying 1 in 3 persons. And so what we are hopeful that we are able to do through our incentives and programs is to get people to understand the pre part of prevention. We want people to utilize primary care and community health and not as much utilize the ED when things have become, just pretty much uncontrollable, right? And so in doing so, it's creating literature that people can refer back to. People say, oh, I have enough pieces of paper. I don't need one more piece of paper. So alongside this literature, we've created a program, a community coach program, in which we are employing people that live in these communities that are highly affected. And they are serving as the liaison between medical care and the community member. A lot of community members are just really afraid of going to the doctor. They don't truly want to know. And then you have others that are willing to go to the doctor, but they may not know the right questions to ask. And so we are trying to help in a sense that we're putting assessments in the communities that will give them an idea of where their chronic disease it currently lands, right? So through these biometric assessments, we're checking the person's A1C, their cholesterol, their blood pressure, height, weight, BMI checks, and then we're giving them a form that has all of these evaluative numbers on those forms. They can then in turn take this form and have an informed conversation with their primary care physician. If they don't have access to primary care, we're connecting them back to an equal access program or a federally qualified healthcare center that can help them get to the next best step as it relates to their chronic disease management. We're talking with people about the importance of diabetes education classes. We have them all throughout the city, but if no one knows about them, what's the purpose of having them, right? And it's not in an effort to recreate the wheel, but it's in an effort to identify the things that are already available in the community and connect the community individuals back to these resources. So in that, it's forming a relationship with the American Diabetes Association, using literature that is already available, teaching communities what My Plate really means. Like you can give them a copy of the My Plate chart, but if you don't explain to them what all those colors are, it's useless. And many of the folks that we are encountering, they're on a 5th grade reading level. And so if you give me a My Plate chart without explanation, I can't tell you that I'm going to appropriately follow it because I don't know what I'm following, right? But when you have a person that lives in my community that looks like me come out and explain My Plate to me, the conversation goes a little bit easier. And so that's what we've learned. There are plenty of champions in these communities that want to see their community have a better health ranking, but they didn't know where to start. So we brought them in, we gave them the appropriate training, and then we deployed them back into their communities to help best serve the community members that they live, work, and play around. Even outside of the community coaching, we have a good nutrition initiative that we're doing with our mobile market. So we have a mobile grocery that goes out into roughly 29 neighborhoods here in Birmingham and Jefferson County. And with this, we are trying to teach people how to shop appropriately based on their chronic disease state. If you're a diabetic and you're telling me I want you to eat better, and so I'll go onto the market and I'll buy all of the fruits and vegetables that you have available, but you also should educate these individuals on the importance of knowing the vegetables and the food items that have naturally producing sugars. So we want them to eat better, and they think in turn that fruits and vegetables means I'm eating better, but it could cause more harm than good. So we're placing dietetic interns or dietitians on this mobile market to say, this is how you read a nutrition label. Yes, I want you to eat more canned green beans than I do want you to eat, fruit cups that have added sugar. But if you eat the entire can of green beans, that poses an additional problem. So helping people not only manage where they currently are, but we're trying to eliminate the co-occurring conditions. So we don't, if you're diabetic, it doesn't mean you have to be diabetic, hypertensive, and have high cholesterol. We're wanting people to learn how to manage their conditions in a way that they are the ones that are in charge. It's really easy for us to say you want people to do better, but if you try to force things on them, it doesn't always go over as well as you would expect it to do. So education is our primary goal. And when you think about the continuous glucose monitoring, very strong proponent of it because it works. And those are the type of things that need to be in place, but you have to also get the person that is utilizing this monitor to understand the importance of keeping up with what is happening with the monitor. Okay. And so one of the things that we've been working on with the American Diabetes Association is the education around those monitors and not being afraid of them. When you tell someone they have to wear something all the time and they have to make sure that they're keeping up with their readings, you probably lost them, right? They'll say, oh, I'll just take my insulin. I'll stick my finger every once in a while. The way I've been doing it since 1984 works just fine for me, right? They don't understand the amount of their life that they get back by having something like a continuous glucose monitor, that it is, as my grandmother would say, it's smarter than me because it tells me when something's wrong with me. And that keeps them well informed, as opposed to the person that wants to eat that one piece of pound cake that's really not going to be a big problem until it's a big problem. And on your monitor will say, all right, time to cut the pound cake. Like it may have been good while it lasted, but we're approaching a dangerous threshold. And so very strong proponent of it, but the education around the monitor is very important because people would be willing, I think, more willing to utilize measures of that nature if A, they were available to more folks, and B, if it was better explained that it gives you back a high degree of your livelihood by having something of that nature as a part of your healthcare regimen. Thank you.
Thank you, Dr. Chambers. That was great. That was a great explanation. And education is everything. Education is power. And you're absolutely right. Like just accessing the CGM is only the first step. You have to make sure that you understand how to best utilize it, how to track your trends, how to communicate with your doctor, communicate with your family members, especially if this is a child or someone who's younger. This is the first time using a medical device. We want to make sure that we're providing them with the best possible support. I'm so sorry. My lights keep going in and out, and my coworker is coming in and dancing around trying to get the lights to turn back on, and it is taking everything in my body to not laugh every time she does it. Okay. Anyway, thank you, Dr. Chambers. Greg, I'm turning it over to you to discuss more about sort of the state of play in Alabama and what's occurring across the South when it comes to CGM policy. And yes, I know we have a slide deck and we're pulling it up for you. Here you go.
Okay. Do I, well, thank you, Kenzie. Do I advance this myself or just tell you when to move the slides, or how does that work?
Yes, my coworker Alicia will just, every time you come to an end, just say next slide and she'll change it for you.
All right, that sounds great. So I guess next slide. So my name is Greg Howe. For those of you that aren't familiar with the Center for Healthcare Strategies, just quickly, we're a nonprofit health policy resource center. We're based in New Jersey, but we work with Medicaid agencies around the country in a variety of ways and in a variety of areas related to delivery system and payment reform, building capacity and Medicaid agencies themselves, integrating care for complex populations. But again, we focus on Medicaid. Next slide. So I just wanted, before I jump into the coverage, what we've seen around the country in terms of coverage for CGM, I just want to mention a project that we're currently involved in, which is funded by the Helmsley Charitable Trust, and we're very grateful for that funding. And we've been working with them for a number of years on this topic. And our current initiative is called Accelerating Access to CGMs and Medicaid to Improve Diabetes Care. There's three parts of this initiative, and I'll kind of explain why that's important to you. The goal is to increase CGM access, improve clinical health outcomes and quality of life, reduce healthcare costs, and reduce disparities for beneficiaries with insulin requiring diabetes. So that's the focus of the project, and we're doing that in three ways. One is through an access accelerator, where we've put out an application for states to receive technical assistance and some financial support through the project. We're working with 7 states, Texas, Oklahoma, Kentucky, Iowa, South Dakota, New Jersey, and Michigan. And each of those states is involved in a number of projects to increase access. So either making policy changes in their states, or focusing on provider and patient education, looking at data to determine the effectiveness of their programs, and looking at ways that their beneficiaries who need CGMs, who aren't getting CGMs, can actually get them through that program. And I also wanted to highlight that we also have a component of the program called the Policy Navigator. I put a link here, and hopefully the slides can go around afterwards. But the Policy Navigator is a way for states to get short-term targeted technical assistance. So the reason I'm bringing that up is I'm hoping that Alabama, the state Medicaid agency, if they're interested, could reach out to us, and we would be happy to work with them to share what we've learned from other states and our work in working directly with other state Medicaid agencies in terms of expanding access to CGMs through their policies. And we developed a resource center to help states do that, and I'll have the link for further along in the presentation. But the resource center really has a lot of great resources and touches on some of the things that both Nancy and Dr. Chambers touched on earlier. So there's a lot of information about why CGMs are important, the sort of the cost savings, quality of life, a lot of studies and research around equity and reducing disparities in diabetes outcomes and care. So I really encourage, even if you're not from a state agency, that you could take a look at that. And there's a lot of great resources there, as well as resources for states making policy changes. It's really, I think, a great place to start. And I would encourage you all to encourage your Medicaid agency to take advantage of that. And like I said, and I know I'm repeating myself, but we're really interested in helping, we're nonprofit, nonpartisan, and we're just trying to help states that want to make a difference here. So next slide. So the program that I just described that we're working on now is based on recommendations from a report that we did back in January of 2022. And there's a link here to that. It's on our website. And what we found is that there's no consistent Medicaid CGM policy across states. There are common components among the different Medicaid programs that cover CGMs, but there's not like a consistent policy. And CMS, the Centers for Medicare and Medicaid Services, don't set that policy. It's up to states to do that. So every state has a slightly different policy, and Alabama is no different. Those differences, just to drill down a little bit, relate to which patients are eligible, which populations. In the case of Alabama, Alabama covers CGMs for the pediatric population. Other states cover CGM for everyone with type 1 diabetes. Some states cover for everyone with type 2 diabetes. Some states cover for type 1 and type 2 only for people who require insulin. Some states specifically cover gestational diabetes, and other states don't. And other states allow pregnant people with gestational diabetes to get CGMs. So there's different ways that states do that. And also states vary in terms of who can prescribe a CGM. There are limits around endocrinologists versus primary care providers. And also the way that the device itself is delivered to patients either through a pharmacy channel or through what's called a durable medical equipment supplier. And when states add these barriers and guidelines and restrictions, they can really present major challenges for people living with diabetes and lead to disparities in outcomes. Next slide. So there are a couple of key things that states are doing that have been happening over the last few years around policy specifically related to CGMs. One is to transition from, as I mentioned before, a durable medical equipment benefit to a pharmacy benefit. And what we've heard from patients and what we've heard from states that are doing this is that it really allows patients who already access their pharmaceuticals through a pharmacy to avoid having to go through another entity, which is the DME supplier. So it's much more convenient for one thing. And also states are able to remove the prior authorization when it is a pharmacy benefit. It's much easier to do it that way. And a number of states have taken that approach as well. So in some states, CGMs are available through the pharmacy. There's no prior authorization to do that. If the doctor orders that, then patients are able to get that device. And then I kind of mentioned this a little bit earlier, that states are really moving to expand coverage for CGM beyond just type 1, people living with type 1 diabetes, to anyone who requires insulin, and even beyond that to anyone with type 2 diabetes or gestational diabetes, whether they require insulin or not. Next slide. So I wanted to just highlight an example of a state that's recently changed its coverage. Texas is one of those states that's in our cohort of states that we've been working with. And they're following the Centers for Medicare and Medicaid Services, CMS, in April of 2023, revised its coverage policy for CGM. And a lot of states are looking toward that policy and trying to align their policies with those new guidelines. So as it says here, the new policy covers all people with diabetes treated with insulin and those with problematic hypoglycemia, whereas before CMS required multiple daily insulin injections or use of a continuous insulin pump for CGM eligibility. So, and that had to be documented, which is very cumbersome, as you can imagine. The other place that states are looking for guidance is the American Diabetes Association Standards of Care in Diabetes, and those are updated annually. So when Texas approached their coverage changes, they looked to both of those sources for guidance. Next slide, please. So in Texas, what the changes actually look like in practice for people with diabetes are that the provisions that were related to insulin treatment and hypoglycemia that were included in the previous policy had a result of excluding most of the beneficiaries with type 2 diabetes. So those were removed. The clinical requirements, as I kind of alluded to before, were more onerous for members with type 1 diabetes, requiring multiple finger stick blood glucose tests and to monitor or to document that, and multiple insulin injections each day in order to qualify for a CGM. So the state's new revised policy, which went into effect in February, it simplifies that clinical criteria for coverage and eligibility and expands access to CGMs through Medicaid and through their managed care program. And also Texas's new policy covers members with gestational diabetes. Next slide. And just a word about gestational diabetes, just some resources that are available to you all. And I know that maternal health is very important to the work that you're doing. But just to give an example of a state that has very clear language about covering CGMs for their beneficiaries with gestational diabetes, basically any member with diabetes in pregnancy, childbirth, or puerperium period, either insulin or non-insulin treated, do not require prior authorization to access a CGM. So it just removes any sort of prior authorization or requirement there. And then in our resource center that I mentioned earlier, we have two excellent articles that could be helpful as in terms of evidence as you're working with the state or with the legislature to expand access. The first one summarizes the evidence base for the prevalence and cost of gestational diabetes among Medicaid members specifically, and the clinical impact for those members. And they also include cost savings, which is really interesting, and I think would be really helpful for the state to be able to have some real numbers there. And then the second article basically provides evidence for sort of the clinical evidence that their findings were that patients were more likely to have lower A1C levels at the end of the pregnancy, experience less gestational weight gain, and give birth to infants with lower birth weights compared to those using blood glucose monitoring. So I think those are two really important articles that could support the work that you're doing. Next slide. Again, I keep talking about the Resource Center, but I think it really is a good source of information for you all. And we have resources around the CGM fundamentals, which I know that that you all covered and touched on, clinical outcomes, health equity, stakeholder engagement, education, policy and coverage implications, fiscal impact. A lot of times states want to know how much this is going to cost if they expand a benefit. And then very tangible resources on state experiences and what's happening around the country. And then there's a link to the resource center there. And I just want to say that, we started, one of the reasons this project is so important to us is because it's because of the focus on health equity and reducing disparities. And we know that Medicaid agencies that we work with, this is very important to them. And we feel like this is a very tangible way to make a difference in that area. So, we all know the benefits of using a CGM, just the amazing change in the quality of life. And we feel like this is sort of a no-brainer, and we want to support states to make those changes. And we're very heartened, I guess, that the states we've been working with in particular have been very eager to do what's right for their beneficiaries. Next slide. And just the link to our just our general homepage or our general webpage, but you can find all the other resources that I talked about earlier, and happy to answer any questions.
Thank you so much, Greg. We will make sure to pass around Greg's slides, but also all of the resources that he mentioned during his presentation in the follow-up email. So no worries if folks weren't able to catch any of those links. We'll make sure to get them to you. And thank you so much for your explanation about what's going on across the South, and highlighting how not only how important CGM access is, but how interesting it is that neighboring states have taken up this effort and made a significant effort to increase access to coverage. It's really heartening to hear. Now we'll turn it over to a 10-minute question and answer session. Just a reminder to add any questions that you might have to the chat or to the Q&A box. I really want to thank all of our speakers for sharing more about their work and their experience with CGMs and with diabetes. Nancy Meganson, who refers to herself as Midwife Nancy, had to jump off for other forms of work, which we completely understand, but we have two of our wonderful speakers here, Greg and Dr. Chambers. So if anyone has any questions, please feel free to add anything to the chat in the Q&A box. I can get us started. So Dr. Chambers, how can folks who are listening to this call be helpful in the effort to better educate individuals about the importance of chronic disease management and their options for utilizing healthcare tools like a CGM?
Specifically, of course, if you would like to additionally learn about the educational resources available through Live Health Smart Alabama, those can be found on our website, and I'll drop it into the chat box. But education around diabetes management can start anywhere. And so we have relationships with like local pharmacies that are here throughout the community that have medication management programs. There are a lot of people that are on diabetes medications that will often mismanage those and not understand what to do. And as opposed to contacting their doctor, they may speak with their pharmacist who they have a closer relationship with. So most all pharmacists that I know here locally, they have medication management programs. There are diabetes education programs, like I mentioned, throughout the city and the state. And then also the American Diabetes Association is a wealth of information. So utilizing the resource database that they have nutrition education, they have chronic disease management education. It comes in multiple languages. A lot of it is easy to understand. And if it's not as easy for you to understand their language, they do have access to local partners that you can connect with in your community that can better help you understand the language that they have on their website.
Great, that's incredibly helpful. And we can also send around a link to the website in our follow-up email as well for folks to access any of the resources that they have. If Greg, if Alabama were to adopt broad coverage of CGMs for patients with diabetes, how would patients' out-of-pocket costs change?
Well, I think, if patients are, I think if patients are not able to get a CGM and they need a CGM and they have to pay for it out of cost, I think Nancy gave the numbers for how much it actually costs in the hundreds of dollars, plus the recurring costs of the sensors and things like that. So if someone has to, can't get that through their Medicaid as a Medicaid benefit and they have to pay that out of pocket, it's just, I think it's just, they don't get it. They can't afford to get it. And it's just, I think it's as simple as that. I think, yeah, I mean, I don't know, it just boggles my mind. I think there are also the other thing that I was just hesitating for a second because I knew there's something else I want to say about this question. I think it's also like if people may not even know that a CGM is available or even know what it is. So someone living with diabetes that can benefit from a CGM may not even know it's an option because either their doctor hasn't offered it because they know that the coverage isn't available and won't pay for it, or for whatever reason, sometimes even some of the providers don't really understand how they work, so they're a little hesitant to offer that, is what we've heard. So I think that even like at that level of like patients not even knowing it's available, even if they could somehow afford to get one. So I think it's just, I don't know, it's just unconscionable to think that people would have to pay for something like that. That's such a life changing, thing, so.
Yeah. And do you think, in addition to folks not even knowing about CGMs, do you think that there are also like common misconceptions about CGMs that might get in the way of individuals asking their doctors about it? Do you think it's just cost, or are there other things to consider too?
Yeah, I think that could be. I mean, I think that I think with any technology, at least for me, like it's sometimes it's a little overwhelming. So I think maybe just not understanding how it works or what like even like physically what it's like to insert a sensor and the things that go along with it. I mean, that could be a potential issue as well, that folks may not really understand. So. But I see it like I see it as a provider issue, most in a large part it's a provider issue to really understand what's best for their patients and be able to talk with them about what they need.
Mhm. I see a question for Deanna, which is what steps have been taken to talk with Alabama Medicaid about creating a change in guidelines? I'm a nurse practitioner, and Medicaid has changed some guidelines with rule changes when we have asked. That's a good question. I can answer that. There have been efforts over the last 3 or 4 years across the state, with several in-state stakeholders to move this policy change forward, and that is ongoing. So there's been engagement, I believe, with folks at Alabama Medicaid as well as individuals within the governor's office. Okay, thank you for that question. Greg, you talked a little bit about this in your presentation, but when you consider sort of what sort of levers Alabama and states alike can utilize to expand CGM coverage, especially to women with gestational diabetes and children on Medicaid, like what are sort of the immediate levers that pop into your brain?
Yeah, I think just removing some of the restrictions, like the requirement, like, I mean, in Alabama, as I understand it, the state only covers children, and children with type 1 diabetes, like they don't outgrow it. So it's like when they become adults, they if they're using a CGM, they're going to continue to benefit from using a CGM when they become adults. So I think eliminating that, or I don't know if it's actually eliminate or just adding coverage for adults, even with just type 1 diabetes. I mean, setting aside all of the folks that could benefit from the required insulin that have type 2 diabetes, but just allowing those kids who are old enough, I mean, sort of become adults and then aren't covered anymore under that policy. So I think that's one of the obvious things. I think beyond that, I think when states start to eliminate, requirements for multiple, for documenting finger sticks, multiple daily injections, all those kinds of things, I think that's just an onerous, that just adds to the, to the barriers that prevent folks from getting CGMs.
Yeah, that's really helpful. I think we only have a few more minutes for questions, so I'll end with you, Dr. Chambers. When you think about ways that sort of individuals who are either health advocates and who are really like ingrained in this space, or people who just have family members or they themselves might have diabetes, what sort of advice would you give to those individuals who want to sort of jump into this advocacy fight, who like want to make it known that this is something that they care about, or who want to engage with maybe someone like you who is doing sort of this education management? Can you think of any sort of advice you might give them?
I mean, being informed is key, but kind of once you get in it, you have to have the interest in staying in it because it's consistently evolving. And so what probably is the case today will not be the case in 2 months. And they have to also understand, especially here in Alabama, things move really slowly. And so you have to have some patience. But for people that want to be involved in the educational component of chronic disease management and just kind of helping to help push forward the needle in a positive direction, it's just reaching out to resources that are already in the field doing the work. Volunteering at some of these places that are trying to connect back to the community. The community is the key. We can't while we can try to fix Alabama one person at a time, having those additional voices always help. Yes, Deanne, it is very distressing that politicians can't see it the way that we do because we're the ones that are on the front line providing the care. And while we may have a voice, the final decision does not lay with us. So that's kind of disheartening. But I mean, I think that if we continue to push and be the loudest voices in the room, at some point, someone is going to hear what we're advocating for, and we will see some changes come into play.
Yeah, thank you, Dr. Chambers. And thank you to you, Greg, and also a thank you to Nancy for participating in this discussion and helping give everyone who's on this call, including myself, more information about what's going on in the state of Alabama. Gosh, sorry about these lights. It's like constant. I just want to reiterate that we need to expand Medicaid coverage of CGMs, including for pregnant women with gestational diabetes. All of the educational information that we just heard will really play into what my colleague Tasha, who's about to jump on the call, what she will talk about more, which is how to stay engaged. So now that you have more information about the problem, how can you be part of the solution? So Tasha, I'm going to turn it over to you, and feel free. I know Dr. Chambers and Greg, you have other things coming up on your calendar, so feel free to jump off whenever you're ready. But Tasha, I'll turn it over to you to talk more about how to stay engaged.
Thank you, Kinsey. Thank you, everyone, once again for for joining us. Thank you to our fantastic speakers. Nancy, I know who had to hop off, Dr. Chambers and Greg, and to all of you for taking the time to join us today. Kinsey mentioned, my name is Tasha Dawson, and I serve as the Deputy Senior Director of Strategic Partnerships for Families USA. And we hope this conversation sparks some meaningful insights and inspire action towards expanding access to CGMs and improving diabetes care in Alabama. As I'm talking, you may see a poll pop up. And we ask that if you can take the time to answer these short questions, because they really do help us as we continue to stay in this conversation with you and stay engaged with you, and give us good directive and insight as to how to best do that, to work around your schedules, your advocacy, your needs. So just fill that out if you can. If you can't, if you had to hop off, or we will be sending all these resources along again with this short survey out post this session. So we want to keep the conversation going. There are a few ways to stay connected with Families USA, and we hope that you do. So one of those is follow us on social media. That's the easy plug and play, on our LinkedIn, Facebook, X, or Twitter, whichever you feel like calling it, Instagram. We're on all of those, and you'll stay up to date with our upcoming events, our advocacy work, all the things that we have going on in that space and policy space. Subscribe to our newsletters. We have 3 monthly newsletters and a weekly resource newsletter. And in that, we share with our partners on the national and state level all of the things that are going on nationally, statewide. We want to act as a conduit of resources for you and your state partners. And so if you have resources that you like to get out to the masses and cast that wide net, please send them to us, and we will absolutely share them with our partners and our networks. And last but not least, this is a shameless, well, not last, but this is my shameless plug. One of the roles I have here at Families USA is to oversee our annual Health Action Conference. Some of you on this call may have been to one. If not, we definitely would love to see you there. It will be in January here in Washington, D.C. I will drop, oh, no, one of my colleagues already dropped the link in the chat. Thank you so much. And so this conference, and the registration is open now, early bird, is an incredible opportunity to connect with state and national healthcare leaders, advocates, storytellers, community leaders, educators, and just come together, share best practices, resources, share triumphs, share struggles, and really just bring everything in one place as we continue to push forward. And lastly, now this is the actual lastly, we offer targeted support. So if you have any questions, if you would like to help developing your advocacy efforts in this area, feel free to reach out to myself, any of my colleagues on this call. We'll give you more information on exactly who you can reach out to and how you can reach out to us for additional questions or needs. We really want to be a partner with you. We want to be in this fight with you. And so to do that best is for us to just listen at how best we can do that for you. So with that said, we just want to thank you again, and we look forward to staying connected with you in this conversation in the future. And Kinsey, you can reach out to her, and as she's going to she put her email there, and we'll also be sending a follow-up email with this recording with the resources from all of our speakers, including more information about where they are, where they're working, and their information. So with that said, we hope that you stay safe, that you stay dry as possible. I know that you guys have the rain and the hurricane there, and so our prayers and thoughts and everything are with you. And our doors are open, and so are inboxes. So please feel free to reach out to us if you have any other questions, comments, concerns. Thank you again so much, and have a wonderful week and weekend. Thank you, Kinsey. Thank you, everyone.